Welcome to the cardiology lecture on pulmonary hypertension. In this comprehensive script, we will explore various aspects of pulmonary hypertension, including its underlying genetics and molecular pathways, classification systems, associated conditions, pathological changes, treatment options, and more. By the end of this lecture, you will have a deep understanding of the complexities surrounding pulmonary hypertension and be equipped with the knowledge to tackle diagnostic challenges and formulate effective treatment plans. So let's begin our journey into the fascinating world of pulmonary hypertension. Pulmonary hypertension is a complex disease influenced by genetics and molecular processes. The BMPR2 gene, for example, plays a role in regulating vascular homeostasis. Mutations in this gene disrupt normal functioning, leading to aberrant signaling and the development of pulmonary hypertension. Understanding these genetic abnormalities is important for diagnosis and treatment, as it can help identify patient subgroups and guide therapy decisions. Ongoing research is focused on identifying more genetic markers and unraveling the molecular pathways involved in this condition. A classification system for pulmonary arterial hypertension, PAH, helps guide diagnosis and treatment. Group 1 includes idiopathic PA, while other subgroups are based on causes like genetics or drug-induced PA, or associations with conditions like connective tissue diseases or congenital heart diseases. Pulmonary hypertension due to left heart disease, PH-LHD, occurs when increased pressure in the pulmonary vasculature is caused by left-sided heart dysfunction. This is primarily due to pulmonary venous hypertension resulting from left ventricular failure or valvular heart disease. Management involves improving left ventricular function, addressing valvular abnormalities, and controlling pulmonary hypertension. Portopulmonary hypertension, POPH, is a form of pulmonary hypertension that occurs in patients with liver disease. It is diagnosed through various tests and can be treated with a combination of medical therapy and liver transplant evaluation to improve patient outcomes. Chronic thromboembolic pulmonary hypertension, TEPH, is a form of pulmonary hypertension caused by chronic pulmonary embolism. It leads to increased pulmonary vascular resistance and progressive hypertension. Surgical interventions, like pulmonary endarterectomy, are the primary treatment for eligible patients. Early diagnosis and referral to specialized centers are crucial for optimal outcomes. In this video, we will explore the pathology and histopathological changes in pulmonary hypertension. Specifically, we will examine the structural alterations that take place in the pulmonary vasculature and how these changes contribute to the progression of the disease. By studying the histopathological features, we can gain valuable insights into the underlying mechanisms of pulmonary hypertension, assist in its diagnosis and classification, and inform the development of targeted treatments. Elevated pulmonary venous pressure can lead to the development of pulmonary hypertension. Pulmonary venous hypertension arises from various etiologies, such as left-sided heart failure, valvular heart disease, or constrictive pericarditis. Persistent elevation in pulmonary venous pressure results in backward transmission of pressure to the capillary bed, leading to pulmonary vascular remodeling and pulmonary hypertension. Diagnostic evaluation of patients with pulmonary venous hypertension includes echocardiographic assessment, invasive hemodynamic measurements, and imaging studies. Management strategies focus on optimizing left ventricular function, relieving volume overload, and alleviating pulmonary hypertension through appropriate medical and surgical interventions. Intravenous prostacyclin therapy remains a cornerstone in the management of severe pulmonary hypertension. Prostacyclin, a naturally occurring vasodilator, exerts its effects through various intracellular pathways, ultimately leading to vasodilation and inhibition of platelet aggregation. Administration of intravenous prostacyclin requires close monitoring due to potential side effects, such as systemic hypotension and site-related complications. Managing these potential risks while maximizing therapeutic benefits is crucial for optimizing patient outcomes. Understanding the mechanism of action, proper administration techniques, monitoring protocols, and potential side effects of intravenous prostacyclin therapy are essential skills for healthcare providers managing patients with severe pulmonary hypertension. Systemic sclerosis, an autoimmune connective tissue disease, often presents with various vascular abnormalities, including pulmonary hypertension. The exact pathogenesis of pulmonary hypertension and systemic sclerosis is complex and involves immunological dysregulation, vasculopathy, and fibrosis. Identifying and monitoring pulmonary hypertension in systemic sclerosis patients is crucial as it significantly impacts prognosis and patient management. Treatment strategies focus on vasodilator therapy, immunosuppression, and managing other systemic complications associated with systemic sclerosis. A multidisciplinary approach involving rheumatologists, pulmonologists, and cardiologists is necessary to provide comprehensive care to patients with pulmonary hypertension secondary to systemic sclerosis. Eisenmenger syndrome, a form of pulmonary hypertension, occurs in patients with certain heart defects. It causes increased blood flow to the lungs and challenges in management. Treatment involves medications, anticoagulation, and possible transplantation. Proper evaluation and understanding of this condition are crucial for effective care. In this video, we will focus on the BMPR2 gene mutations and their significance in pulmonary arterial hypertension, PAH. We will explore how these mutations disturb vascular homeostasis, leading to abnormal cellular proliferation, inflammation, and vascular remodeling. Additionally, we will discuss the importance of identifying these mutations for disease prognosis and management, including the role of genetic testing and counseling. Ventricular arterial coupling in pulmonary hypertension involves the relationship between left ventricular function and arterial load. Increased pulmonary vascular resistance leads to greater workload on the right ventricle, which can be assessed using imaging techniques. Optimizing ventricular arterial coupling through various therapeutic approaches improves outcomes for patients. In conclusion, pulmonary hypertension is a complex disease requiring understanding of genetics, molecular pathways, classification, associated conditions, and treatment options. This knowledge equips you to diagnose, manage, and research pulmonary hypertension effectively. Thank you, and continue to expand your knowledge for optimal patient care.